Tushar, and it's really heartwarming to see you here. It's really nice that when you take up a course like this thing, you realize that you have gone long way, and I mean we considered you as a student, and when you see you here, you realize how long jump you have taken, and I'm really proud of you. Thank you. So, we're talking about uneventful surgery and post-op trouble. So, I have divided them into different parts. One, the problems which are in front of the flap or before flap, and something which is under the flap. Uh, for the paucity of time, I don't think I can include everything, but we'll just try to take little things of everything. So first and foremost, severe dry eye. Well, dry eye is quite multifactorial when it comes to LASIK. One of the factor is when we make flap, we are sort of severing the nerve endings, and that reduces the corneal sensation and reduces the secretion of tear film. Same time, it can also reduce the blinking, and it can reduce the meibomian expression also. So both ways you can have evaporative as well as tear film deficient dry eye possibly with that. Second is when you're using the drops, when you're using your suction devices, when you are operating upon these patients using topical anesthetic agents and all those things, they're going to kill few of the goblet cell, and that also can potentially lead to an evaporative dry eye. And apart from all these things, it's said that its altered shape can lead to tear film breakup time. Now, having said that, all these things are more theoretical, where you extend your imagination and blame everything on some different factor. But not every patient of LASIK has dry eye. And same time, we know that without LASIK also, they're going to have dry eye because of their young age and whatever kind of lifestyle they have. So let's not blame everything on LASIK. But if somebody has significant aqueous deficient dry eye and has any other systemic anomalies along with that, it may not be the smartest idea to go ahead with the refractive surgery. Losing one patient is pretty okay versus having problem later on. Uh, Treatment of dry is simple. Whatever we treat dry normally, you're going to treat it here same way. Uh, Anti-inflammatory molecules like cyclosporin can be of help, and you surely would want to continue these molecules in dry patients post LASIK. Coming to the next part, which is flap dislodgement. Flap dislodgement is not very common, but any traumatic incidents or any direct trauma on the eye can have flap dislodgement, and that's the advantage of SMILE, where you are not having a flap dislodgement, whereas LASIK can potentially have flap dislodgement. Uh, it it's an emergency, and it can present in the middle of the night, and you have to take up these patients as early as possible. If they present to you early, which is post-op early, it can be related to excessive squeezing or eye rubbing, and such kind of thing can present on your next day follow-up, and you can see dislodged flap. Having said that, I have had such kind of thing in past, uh, where I don't have habit of seeing my patient post-operatively, where I don't call them down in OPD to see if everything is fine, which is not the best habit. Most of the surgeon I would advise should see the patient post-operatively. But I knew that I see my patient intraoperatively both eyes after finishing, and I had a couple of such incidences, and it was interestingly with one particular fellow who was doing the surgery, and then I thought about it, and I realized that it was always right eye. And then I realized while doing the left eye, he was sort of poking the right eye by possibly putting his finger there to take support. And that's when I realized that initially in the beginning of your career, you might want to put a shield on your right eye, on the patient's of right eye of the patient while operating the left eye. If not, just be aware that your hand should rest on forehead and not on the eye. But it's certainly not as common. If it's longer than 24 hours, we know that it's mostly related to trauma, and it's not just related to squeezing and all such kind of thing. Uh, how do we treat it? Well, if it's a partial flap dislodgement, you might want to just reposit the flap, and you might want to iron the flap multiple times. You might want to wash the flap enough, because remember, there would be a debris, lot of debris which can enter there, and then you can simply put a BCL there, which can be kept for a little longer time. But if it's a little bit larger area of dislocation, or sort of complete dislocation, you might have to take care of these things little more than those things. You might have to suture the flap, and you might have fixed folds there. Anything which presents a little later on, be aware that there can be potential chance of microbial keratitis here, and just do not leave them and have them for closer follow-up. So what happens if we do not treat them? Well, you may end up in macrofolds, or large fixed folds or striae. You can have epithelial ingrowth, and these things are not the best thing. As we said, that Flapstria is one of the complication here. The Flapstria is something which is not uncommon, especially with MK LASIK. Flapstria is a little more common compared to FS LASIK, but there also you can have Flapstria. Uh, Flapstria and microfolds are not same, so do not get confused with it. Whenever you have any treatment, laser-based treatment, which you do for a high refractive error, the curvature of the cornea changes significantly, and now the flap configuration is a little different than pre-operatively, and you may end up having small micro stria there. They are not to be worried about. How do we know whether you should be worried about this thing? Well, you stain them, and if they have negative staining, that means the folds are quite deep. Also, they induce Maddox rod effect. So if patient has astigmatism post-operatively, best corrected vision is not improving, and if you are seeing, or patient is perceiving ghosting image, or on your abrometry you are seeing high rod aberration, but those guys do require treatment. Treatment wise, it has to be operated under your regular microscope. You always want to keep them dilated so that you can get a retro illumination glow. uh, you have to debride their epithelium, because it goes into fixed folds, and epithelial debridement is absolutely mandatory. You lift the flap, you hydrate the flap, and the idea behind hydration is that it swells up the cornea, or swells up the flap, and that itself takes away a few of the folds. Having said that, is in spite of all these things, there would be impression of these folds which will still be there. They're not folds, don't worry about them so much, they'll disappear on its own. You can reposit the flap by stretching it and all those things. There are irons available which can be put on the cornea and all those things. Some people use heat also, and you can use suture or fibrin glue, but they're not always mandatory. Then comes the problem beneath the flap. First of them, diffuse lamellar keratitis. It's certainly not uncommon in any interface-based procedures. Wherever you create interface, you can have cellularity in between, and which the cause of that we still don't know, but we do blame it on different things like povidone in gloves, or mevomin secretion, and many more things to come. But we still really don't know the cause of that. Stage wise, it can be a very small amount of diffuse lamellar keratitis in periphery, which you see in FS LASIK, uh, which is absolutely not even worth calling DLK, but it's something similar. Anything which goes beyond, well, we start staging them from stage 1 to stage 4. Stage 1 is very few cells, and stage 4 is very confluent cells, and with flocculence there, and those guys need to be treated by lifting the flap and cleaning them up. Cleaning the flap is certainly not a big deal, but remember, whenever you lift the flap, you have chance of epithelial ingrowth. So more the number of lifts, more are chances of epithelial ingrowth, and be aware of that. Post-op, they need topical steroids, and usually they do well. If it's very severe, grade 3 and grade 4, you can have potential scarring, and you may have even small hyperopic shift also there. Next comes central toxic keratopathy (CTK), though not very common, but if you're there in the field for longer time, you would have seen this thing. Uh, the picture is very very characteristic, and if you remember this picture, you are not going to miss this thing. Nothing looks like this thing. It gets confused with stage 4 DLK, but when you see these folds, it's nothing but CTK. uh, we really don't know the cause of this thing, and it's not infective, and it's certainly not as inflammatory as we see in DLK, where cellularity, there is no cellularity here. There are huge gaps of stroma, which when you do confocal microscopy, you see there, and this is acute apoptosis which occurs, and it leads to a hyperopic shift. Topical steroids do not have much role here, but for your psychological benefit, you might want to put them on topical steroid, but ultimately it's just wait and watch, and ultimately they end up having hyperopic shift. You can repeat laser on top of it to treat that hyperopic shift, and they do usually well. Next is the pressure-induced stomal keratitis (PISK). Again, not very uncommon, because 20% of the population can have the gene of steroid responder. So it's just question of time. You may come across typically bilateral, typically DLK without much of anything, and typically you may miss because the softy, spongy cornea, which underestimates intraocular pressure. And just be aware that any such kind of case bilateral, which those were normal, might have PISK. All you need is ASOCT, document the fluid underneath, as you can see from here. Start them on anti-glaucoma medications, and they usually do well. Next comes microbial keratitis. Certainly not very common. Microbial keratitis is something which was earlier seen, but remember, uh, more greedy you are, more are the chances where you end up in such kind of thing. When I say greedy, it means that if you're doing MK LASIK, you want to reuse the blade by cleaning it something. These are breach in protocols, which you certainly don't want to take chances, and there you can have potential microbial keratitis. It's in interface, so relative oxygen pressure is low there, so most of the organisms are one which are anaerobic, or they rather thrive in low oxygen pressure. One of them is atypical mycobacterium and nocardia. Those guys are notorious to be there, and sometimes very difficult to treat them. uh, Flap lift and scraping is absolutely mandatory, and there is no role of empirical treatment there. The lift itself reduces the load of the organism, and hence it's very very important to lift the flap there and treat them. uh, Treating them requires sometime even the wash, and hence when you lift the flap, you might want to combine wash along with this thing, so that you can get rid of the organism as early as possible. I really don't think we have enough time to discuss about detail about this thing, but to conclude that the complication following refractive surgery, they are sort of emergency, and which can lead to significant ocular morbidity, and appropriate treatment on time is something which is very very important. It's better to prevent than to cure, and treatment is always better than no intervention. Thank you very much.
Thank you so much, sir. That was really nice, and I'm